Pharmacological management of hypertension. Imagine this. Three patients walk into your clinic and all three have exactly the same blood pressure, 170 over 100 millimeters of mercury. The first patient has diabetes with protein in the urine. The second has heart failure with swollen legs and breathlessness. The third is a 30-year-old pregnant woman in her second trimester. Should all three receive the same antihypertensive drug? Absolutely not. In hypertension, the blood pressure reading is only half the story. The underlying disease determines which drug you choose, and sometimes which drugs you must never prescribe. In this video, you'll learn the complete stepwise pharmacological management of hypertension, from first-line therapy and combination treatment to resistant hypertension and the drug of choice in every major clinical condition. Stepwise treatment overview. Let's first understand the overall philosophy behind the stepwise treatment approach for hypertension. The goal is simple: achieve adequate blood pressure control while using the fewest medications necessary. Treatment therefore progresses in a logical sequence. We begin with monotherapy, where a single first-line antihypertensive agent is selected based on the patient's clinical profile. If blood pressure remains above target despite an adequate dose and good adherence, we move to dual combination therapy by adding a second drug from a different class. Using complementary mechanisms of action produces a greater reduction in blood pressure than simply increasing the dose of one drug. If control is still inadequate, treatment is escalated to triple therapy, combining three complementary antihypertensive agents. Finally, patients whose blood pressure remains uncontrolled despite optimal triple therapy are considered to have resistant hypertension. These patients require evaluation for secondary causes of hypertension, assessment of medication adherence, and consideration of advanced pharmacological options under specialist supervision. The key principle to remember is that hypertension is treated step by step, with each stage adding agents from different drug classes to maximize efficacy while minimizing adverse effects. Step 1. Initial monotherapy. In patients with newly diagnosed hypertension, treatment is usually started with a single antihypertensive drug, also known as monotherapy. The choice of drug depends on the patient's age, associated diseases, and overall cardiovascular risk. There are three major first-line options. The first is a thiazide diuretic, which is a first-line option because it effectively lowers blood pressure by reducing volume overload through increased excretion of sodium and water. The second option is an ACE inhibitor or an ARB. These drugs lower blood pressure by blocking the renin-angiotensin system, thereby reducing vasoconstriction and aldosterone-mediated sodium retention. The third option is a calcium channel blocker, which primarily lowers blood pressure by reducing peripheral vascular resistance through relaxation of vascular smooth muscle. Steps 2 and 3. Combination therapy. If a patient's blood pressure remains above the target despite initial monotherapy, simply increasing the dose of the same drug is often not the best strategy. Instead, better blood pressure control can usually be achieved by combining drugs from different classes because they lower blood pressure through complementary mechanisms while minimizing dose-related adverse effects. In step 2, dual combination, we combine two agents from different classes. Common and evidence-based combinations include an ACE inhibitor plus a calcium channel blocker CCB, or an ARB plus a diuretic. If blood pressure is still not adequately controlled, treatment is escalated to step 3, triple therapy. The standard regimen consists of an ACE inhibitor or ARB, a calcium channel blocker, and a diuretic. Step 4. Resistant hypertension. A patient is considered to have resistant hypertension when blood pressure remains uncontrolled despite receiving triple therapy, typically an ACE inhibitor or ARB, a calcium channel blocker, and a diuretic at appropriate doses with good adherence. The most important add-on drug at this stage is spironolactone. As an aldosterone antagonist, it counteracts aldosterone-mediated sodium and water retention, making it highly effective in many patients with resistant hypertension. If blood pressure remains uncontrolled or if spironolactone is contraindicated or not tolerated, additional agents can be added sequentially. These include a beta blocker, which reduces cardiac output, or an alpha blocker, which lowers peripheral vascular resistance. In refractory cases, vasodilators such as hydralazine or minoxidil may be used. Because these drugs can produce significant adverse effects, they are generally reserved for patients whose blood pressure remains uncontrolled despite multiple antihypertensive agents. Hypertension with diabetes and CKD. Let's begin with diabetes. In hypertensive patients with diabetes, ACE inhibitors or ARBs are the preferred drugs because they provide renal protection in addition to lowering blood pressure. They achieve this by reducing intraglomerular pressure, which slows the progression of diabetic nephropathy and reduces proteinuria. This is why these drugs are considered first-line therapy in most diabetic patients, especially when albuminuria is present. In patients with CKD, ACE inhibitors or ARBs remain the first-line antihypertensive drugs because of their renoprotective effects. However, when the GFR becomes significantly reduced, thiazide diuretics lose their antihypertensive efficacy. At this stage, loop diuretics are preferred because they remain effective even in advanced renal impairment and provide better control of blood pressure as well as fluid overload. Hypertension with cardiac disease. In patients with ischemic heart disease, the preferred combination is beta blockers plus ACE inhibitors. Beta blockers reduce heart rate and myocardial contractility, thereby reducing myocardial oxygen demand. This helps relieve angina and lowers the risk of recurrent myocardial infarction. ACE inhibitors complement this by reducing afterload, preventing adverse ventricular remodeling after myocardial infarction, and improving survival. Together, these drugs not only control blood pressure but also improve long-term cardiovascular outcomes. Now consider heart failure. In these patients, blood pressure control should be achieved using drugs that also improve prognosis. The cornerstone quadruple regimen consists of ACE inhibitors, beta blockers, diuretics, and spironolactone. ACE inhibitors and beta blockers slow disease progression. Diuretics relieve fluid overload and congestion, while spironolactone, an aldosterone antagonist, further reduces mortality and hospitalizations. Hypertension in pregnancy. Methyldopa, labetalol, and nifedipine are the drugs of choice for hypertension during pregnancy because they effectively control blood pressure while maintaining a favorable maternal and fetal safety profile. Equally important is knowing which drugs to avoid. ACE inhibitors and ARBs are contraindicated during pregnancy because they are teratogenic. Exposure during pregnancy can lead to serious fetal complications, including fetal renal dysgenesis and oligohydramnios, which may result in poor fetal growth and even fetal death. Key takeaways. Let's conclude by summarizing the key takeaways from the pharmacological management of hypertension. The first principle is to escalate treatment stepwise. Begin with monotherapy, and if blood pressure remains uncontrolled, progressively add agents from different drug classes. This stepwise approach provides better blood pressure control while minimizing adverse effects. The second important point is to remember spironolactone for resistant hypertension. It is the most important add-on drug and should always come to mind when blood pressure remains uncontrolled despite standard triple therapy. Finally, always tailor treatment to comorbidities. Use ACE inhibitors or ARBs in patients with diabetes and chronic kidney disease because of their renoprotective effects. In ischemic heart disease, beta blockers play a key role. During pregnancy, remember to avoid ACE inhibitors and ARBs, and instead use safer alternatives such as methyl-dopa, labetalol, or nifedipine.